having more procrastination than now before, right?
Procrastination coming.
No.
Munadi.
Yes. So because of ortho, procrastination might have reduced now. Not only that, she is having it looks like a VME, vertical maxillary. Yes. Right?
Yes.
The incisal edge is very much down. Actually, if you have taken a repose close, you would have known, right? Yeah. Yes. This is a letter. So, whenever you are placing midline implant, you have to check this view also. So, compared to the midline, how are they? So, always keep eye on this axial. Okay, here also the bone is not very great. Okay, but okay, it's manageable. See here, there is thick lingual cortex, thin labial cortex. The implant is getting stability from this cortex and this cortex. Right, that is, in some way it is good actually. So it is getting stability not from this part, from it is sandwiched between the buccal and labial cortex. So another implant will be placed here. This is second premolar, right? Even distal to second premolar only, mental trauma is happening. This is the first premolar. We see here compared to the first premolar on the left side, here the anatomy is much more bad, like a hourglass appearance, right? What might be the reason? We don't know. Maybe during extraction, the buccal plate might have got fractured. We don't know. Anyhow, we will be doing alveoplasty here. Right? We will be removing this bone. So from here only we are going to place 10 mm or 1.5 mm shorter diameter. Less than 4 we can use. So in this view you can see the mental foramen extensions. Let me see. It may be this one, may be the. This is you can only this one. And here, if you place a shorter implant, the risk is less. Now we are planning for distal mandible. So this is the second premolar. Since we are planning for giving second premolar, we are checking the mesial root. Okay, if you check the mesial root, the root is very much wider buccolingually. So if you place an implant, most of the implant is outside the socket. Nothing wrong. But a small trick is if you push it slightly mesially, starting the drilling from the mesial crest, then you are in good form. So this is that small trick. So starting the drilling from this tip, this crest entrance, and drilling should be towards, not towards the socket. Away from the mesial to the socket. Here the thing is, the canal is little closer. See, usually this is the depression, right? The canal will be below the depression usually, but here it is
About it.
above. So we should be little extra careful. So a short implant will do and thinner diameter. So when the nerve is closer, better use a thinner diameter. Tenon is enough. Or what we will do is we will put it entirely in the interdental bone. That is also a good option. Right? There it is much more favorable also. Here the canal is little bit away. Even if you put the implant straight, you can place a 10 mm implant. This is a safe option. 4 into 10 now. You see, close to lingual border, you can place a longer. 10 mm is more than enough. We are checking the mesial root of 6. The mesial root of 6 is not very much ideal because the root itself is very much wider infection. So we will try the same technique, interdental. This is the interdental bone. Interdental bone. The bone is good, even though it is just above the. And the further we can place a 10 mm implant. So the distribution is also good. Now we are going to the left side. Very exactly above the mental foramen. This is the interdental bone, right? Here also we can place implant. 10 mm is enough. And distal root of 6 we check. And there is a periapical infection is there, keratosis. So more than that, if you go to 7 area, distal to the distal root of 6, here the bone is good. You can place even a straight implant. That's good. 10 mm implant will do. See the canal. The width is also good. Sorry, implant. So upper we have planned for a bar, right? The sinus is expanded till the 6 and 5 and 4 and it comes till the distal aspect of the canine. Here also, right? Even in 4 region, the sinus floor is going very low. So 6 no bone, 7 no bone. So can you place a good implant in 5 axially? No. Can you place a good implant axially in the 4? No. Okay, because we have to do mandibuloplasty also because the patient is having gummy smile. See, if we remove this bone, right? We remove this bone, then the remaining available bone is much lesser. So definitely, can you place implant in 6? No. Right? 5 also no. So either you can start from 4 and tilt it mesially or place the implant in the canine. Core pterygoid looks good. So definitely the inter-implant distance will become more. Number of implants which we place becomes less because here we cannot place, here we cannot place. So this, if you use bar, then it becomes long term. It is a very useful. Now we will. The key locations are 2 pterygoids and 2 anteriors close to nasopalatal canal, and 2 more in the canine or premolar. So totally it's a 6, around 6. That's it. If you place the 6 good implants, nothing more is needed. Especially adding pterygoid will give